So Dr. Rizoli has been previously introduced and doesn't need further introduction from that regards, but we'll be talking about traumatic brain injuries. Who needs a repeat CT?
So once again, I want to thank Dr. Perry, Dr. Ball, Dr. Ree, Norika, Salvino, so many of you for the invitation. I'm really happy to be here. Thank you very much. So let's talk about, I look at here and said, oh, it's the wrong title. Let's look here. Let's talk about, do we have to repeat a CT head in a patient with a head injury? So there's a very clear question. Do our patients need repeat CT head? Those are my disclosures, and on the disclosures that I'm going to use 2 slides from my previous presentation. One of them is that traumatic brain injury is devastating and very common. I'm always impressed with the numbers of Canadians that have a head injury every day. I'm even more impressed when I see the world. I still think that Canada is one of the safest places in the world, and still we see every day, we see a number of patients with head injury. I always like to remind that head injury is more common than breast cancer by a huge factor, huge. And it's much more costly as well too. And the only advances we have done in head injury recently have been guidelines. We have standardized care. That's the best advance we have had in head injury. Nothing else has changed for decades. So, and a lot of the evidence that we have are expert opinions. Okay. So why do we do CT scans on patients when they come in with head injury? And I would say it's because we're looking for something that can be treatable. So there's plenty of evidence that patients with head injury, particularly those with severe head injury, they do benefit from having a CT scan of their brain. So I think that every guideline that you're going to read, every protocol that you're going to read, the management of patients with head injury involves CT scan. Right? It's inadmissible that someone is going to be in Canada is going to be seen with a severe head injury and not have a CT of the head. And again, the reason is we're looking for something that can be treated. We're assessing the severity of the head injury, and actually that's giving us an idea of prognosis of that patient as well too. The thing that's interesting is that as our pre-hospital care gets better, patients are getting faster to us, and as we get better in our care, in our timely care, we're actually doing CTs faster and faster, earlier and earlier. And the earlier you do a CT head, more likely you are not to catch everything that's wrong with that brain. So the earlier you do, less likely it is to be actually a definitive CT scan with all the injuries. And the reasons are, again, the same paradigm, that head injury, there's a primary insult to the brain, there's that injury, there's that axon death, there's that neuronal death, and then there's secondary insult that I hope that by now you're thinking catecholamine storm as a secondary insult. I hope that. So we know that about at least 30% of the patients that have the first CT head, at least 30% will progress. And the earlier you do your first CT, more likely you are, if you repeat a second CT, to find something new. And the concern is, if I miss something, or if I find something in the repeat CT, that may be something that could be treated with head injury. So, should we do CT scans? Should we repeat CT scans in everybody? So let's start some arguing here. So the first thing is that at least 30% of the patients progress, meaning that 70% doesn't. Of those that progress, many of them may need surgery, may need invasive, may change the treatment, but in 70% may not. And let's think too, many of us here work in the ICU, it's not that easy, right? So just say, yeah, I'll take the patient down to another CT. Well, it starts that many of our patients are unstable, hemodynamically, they're unstable. They're on multiple drugs. They're actually, many of them have elevated ICP. So if my patient has elevated ICP, am I going to put them on the CT scan flat? I don't know. Right? If they're on pressors, am I going to transfer them to the CT scan? If they haven't their spines cleared, if they have, all the issues, we all that work in ICU can recognize those type of pictures. Many of our patients can't simply go for another repeat CT scan. So how much should I insist? If I have a patient with elevated ICP, how much is worth to actually put this patient flat and send them to CT for a second CT? How helpful would that second CT be to me? Right? That's a good question, and actually it's going to be for you to answer with each one. So just emphasizing here, I'm talking about severe head injury. I'm talking about head injury in the ICU. I'm not talking about concussion. I'm not talking about patients that are going to go home from emerge. I'm not talking about kids. Nothing pediatric here. I'm talking about severe head injury in the ICU. Should I repeat the CT scan? And I'll start by showing Dr. Ree's work. Number one, because I admire Dr. Ree. Second of all, because he has written a lot on the topic as well, too. In fact, I found 5 papers from Dr. Ree on this topic, and they all have a similar message. Maybe routine CT is not necessary. Right, so this is one of the papers that I like the most, a prospective study. Dr. Ree collected about 354 patients and saw those patients who had a repeat CT scan. And the question was, what was the reason for the repeat CT scan? Was because the patient deteriorated clinically or was routine? So deterioration means the patient blew a pupil. So if the patient blew a pupil, you're going to go down for another CT scan for sure. So that's an indication. On those patients, what he found was that 40% of those patients required something active done to them. Required surgery, required an invasive monitor, required something done to them. So yeah, I'd say if the patient deteriorates clinically, they're going to go back they're going to do a CT scan. I want a new CT scan. But of those routinely, that had routine CT head, only one required an intervention. And the intervention apparently was an EVD. Right? So the question is that worth sending all those other patients routinely that don't deteriorate clinically? So this is another study, and now I'm going to show you a series of studies. They don't look much different. This was 2011, Annals of Surgery. Again, 190 patients. 20% of the patients deteriorated clinically, had a CT scan. Most of them required something done. Those who were done routinely, just for doing a second CT scan repeated, no one required an intervention. There was no benefit to routine repeat CT scan. One more study is, there's another study here from San Diego showing a similar one on patients on anticoagulants, actually. So there was no clinical deterioration. Only 1 in 10 had something different in the second CT scan, and that patient never required an intervention. Smith from San Francisco showed again, without clinical deterioration, CT scan doesn't add anything. But then there's a systematic review by Wang that says these numbers are very variable. So changes on CT scan vary from 0 to 50%. Need from surgery varies from 0 to 80%. Number of 0 to... So big variability in here. So it raised some questions. Say basically the indications for repeat CT scan are not clear. And then there are a few more studies that I won't bother you with them. And then we know there are some patients that maybe are at a higher risk. We know the bigger the damage done to the brain, more likely we're going to find progression. In a study that we did here when I was at Sunnybrook, we found out that patients who have coagulopathy were more likely to have a second CT that had something additional, and they were more likely to require interventions. So age, severity of the head injury, the presence of coagulopathy, and there's actually even one study on doing CT perfusion where they found that if it was contrast extravasation, this patient was very likely to have a worsening in the next few hours. So probably you should follow up these patients. Right? Okay, so I'll come to the first conclusion here. And the first conclusion is patients who have head injury need CT scans, part of their initial management. Repeat CT scan, routinely, maybe not indicated. Maybe there are some patients that don't need a repeat CT scan. Patients that have a clinical deterioration, no doubt. Right? A patient was moving, now is not moving anymore, repeat CT. Blow a pupil, repeat CT, and chances are you're going to find something repairable, something surgical on these patients. Okay, so clinical examination, very important. But again, let's go back to the ICU. Most of my patients, I can't examine them. I can't, right? If they are unstable, probably that is nothing. I can't, it's just like trying to do GCS, you know, the vocal part of it with a patient that's intubated. It's hard. It's hard to do physical examination. So now I'm going to twist a little bit. Who are the patients who may not need CT scan? If the indication for repeat CT scans is a clinical deterioration, how do I detect clinical deterioration? Let's say my patient has a direct injury to the eye, so I can look at the pupils. They are paralyzed because they have a bad lung contusion. I can ventilate them. They're on pressors. They have elevated ICP. Should I send them down for a repeat CT? And let's say he's my boss. He's the CEO of my hospital. Then should I send it to repeat CT or not? Okay. So I'm going to switch a little bit things here. I think that CT scan, the way I see it, is a monitor, right? And that's a picture in time. You send the patient out CT, you take a picture of the brain. There are other ways to monitor patients. And the other way is now, that's it. If you work in a neuro ICU, all you're going to be talking about is called multimodal monitoring. Right? That's the word. If you want the answer for anything in neurosurgery today, it's a multimodal monitoring. And those are the indications for multimodal invasive monitoring of patients with head injury from the Trauma Brain Foundation. At the third edition, they were very clear. A patient has a severe head injury and has an abnormal CT, must put an ICP monitor. Right? Now, in the fourth edition, they'll say, well, maybe, I don't know, if you think the patient needs something, then you do it. So I'll just talk about one study published in New England Journal 2012, where they compared patients with head injury that had physical examination and CT, and patients who had invasive ICP monitor and CPP-guided treatment. Who did better? Do you remember this study published in New England Journal? Which group did better, the ones who had repeat CT or the ones who had ICP monitor? No difference. No difference. And actually they did functional outcome too. They did 6-month outcome. No difference. And that's the thing, right? CT is a monitor. You take a picture of the brain. ICP is a continuous monitoring. What happens is that every time you use ICP, you're more likely to find something wrong. You're more likely to intervene. But in the end, the result was the same. This is not the only study. I'll tell you another. This is another Lally study. That's a different one. This is on ICP monitors. He did a retrospective study, again, with David Nathans. They look at 10,000 patients. They saw that in North America, we don't follow the brain trauma foundations often to put ICP monitors. And ICP seems to be a little bit of a maybe survival benefit. Not that much. And then I'll show another study from Holland that was published a few years ago that actually they did the same thing. So they compared patients with severe head that had clinical examination and CT versus patients who had an invasive ICP and CPP-directed treatment. So it was a picture, a photograph of the brain versus continuous invasive monitoring. Who did better? Same finding as a Chestnut New England Journal. Okay? So I think that what those studies shows is that if you have a patient that you have continuous monitoring, then that can be your physical examination. Right? You don't need to repeat your CT head unless the multimodal monitoring that you have in place will show some abnormalities. Right? So either you do physical examination, repeat the CT, or you monitor this patient in the ICU invasively, either with ICP, with a tissue brain monitor, with transcranial Doppler, and so on. Okay? So who needs repeat CT scan? Let's try to put it all together. So patient who comes in with head injury needs CT scan. Who am I going to repeat the CT scan? Patients that deteriorate clinically or that can't leave the ICU, and I'm going to institute multimodal monitoring on these patients, and then they change. Then this patient must have a CT scan. If they don't, I can actually postpone the repeat CT scan they had, right, for these patients. And I always like to remember too, there are a few things that you can miss on the initial CT scan, like a carotid dissection. Remember, patients that don't wake up and you haven't done an angio of the neck, maybe this patient had carotid dissections that you're missing, or venous sinus thrombosis as well too, that you can miss actually on those patients. So, and the bottom line is, in my hospital, usually we tend to do repeat CT scans on everybody who has a severe head, particularly if they deteriorate clinically, but there are few patients who actually can not do it. But those patients, I have to have invasive monitoring, and I have to make sure that that invasive monitoring is showing me this patient is stable and not deteriorating. Okay? So once again, thank you very much. It's a privilege to be here. Thank you.